If a surgeon told you today that your knee needs to be replaced, would you actually know whether you had genuinely exhausted every non-surgical option available? Or would you simply be trusting that someone else had already made that determination on your behalf? This is one of the most consequential gaps in how knee osteoarthritis is actually managed in practice. The research is unambiguous that comprehensive, properly implemented non-surgical treatment produces meaningful, often substantial improvement for the large majority of patients with knee osteoarthritis, and that surgical intervention should be reserved for patients who have genuinely failed this comprehensive approach, not simply tried one or two components of it in isolation. Yet a significant proportion of patients proceeding to knee replacement surgery have never actually received the complete, properly implemented non-surgical treatment program that the evidence supports, often because no single physician appointment provides the time to walk through every component of this comprehensive approach in the kind of detail that actually allows successful implementation. Today I am giving you that complete picture, every major category of non-surgical treatment for knee osteoarthritis that current evidence supports, organized specifically by the strength of evidence behind each one, so that you understand not just what options exist, but which ones deserve priority in your own treatment approach, and exactly how these different treatment categories work together as a genuinely integrated program, rather than as a menu of disconnected options to try one at a time. Before we begin, subscribe to this channel right now if you want this kind of complete, organized, evidence-ranked treatment guidance for knee osteoarthritis. We have covered many of these individual components in dedicated previous videos throughout this channel, and today we are bringing them together into the single, comprehensive framework that shows you exactly how they fit together. Hit subscribe. Let us organize this by evidence strength, starting with the treatments that have the most robust, most consistent research support, because this is where your treatment priority should genuinely begin, regardless of how exciting or unexciting any particular treatment category might initially sound. The strongest evidence base in the entire non-surgical treatment landscape for knee osteoarthritis belongs to structured exercise therapy, specifically targeted strengthening of the quadriceps and hip musculature combined with appropriate aerobic conditioning. The Cochrane database of systematic reviews meta-analysis examining exercise for knee osteoarthritis, synthesizing data across 44 randomized, controlled trials involving over 3,500 patients, found that exercise produced pain reduction effect sizes comparable to those typically seen with NSAID medication, while simultaneously improving physical function and, unlike pharmaceutical intervention, carrying essentially no risk of the cardiovascular, renal, or gastrointestinal adverse effects that we have detailed extensively in our medication videos throughout this series. The specific exercise protocol that this evidence base supports, which we detailed comprehensively in our dedicated knee exercises video earlier in this series, includes quadriceps strengthening exercises performed most days of the week, combined with 30 minutes of moderate aerobic activity, most commonly walking, which we detailed in its own dedicated video addressing the specific pace, surface, footwear, and technique parameters that maximize benefit while protecting the joint. This combination, exercise therapy broadly defined, represents the single most evidence-supported non-pharmacological intervention for knee osteoarthritis currently available, and any comprehensive non-surgical treatment approach that does not place this at the absolute center of the treatment plan is failing to align with what the strongest available evidence actually supports. The second category with comparably strong evidence support is weight management, specifically for patients carrying excess body weight. Given the direct mechanical relationship between body weight and knee joint loading, we have detailed throughout this channel, with every kilogram of excess body weight producing approximately 4 kilograms of additional compressive force transmitted through the knee with each step during normal walking. The IDEA trial, published in the Journal of the American Medical Association, specifically demonstrated that the combination of diet-induced weight loss and exercise produced significantly greater improvements in pain, function, and inflammatory biomarkers than either intervention alone, with patients achieving the greatest weight loss showing correspondingly the greatest improvement, establishing a clear dose-response relationship between weight reduction and clinical outcome that strengthens the causal interpretation of this relationship considerably beyond what correlational data alone would support. This evidence places weight management, for patients where it is clinically relevant, essentially the same tier of treatment priority as exercise therapy itself, not as a secondary or optional consideration, but as a core, foundational component of the non-surgical treatment approach that the strongest available evidence specifically supports prioritizing. Topical anti-inflammatory medication, specifically topical diclofenac, represents the strongest evidence-supported pharmacological intervention in this entire treatment landscape, with the American College of Rheumatology guidelines specifically recommending topical NSAIDs as preferred first-line pharmacological treatment for knee osteoarthritis, preferred specifically over oral NSAIDs for most patients given comparable efficacy combined with the substantially improved safety profile we detailed extensively in our medications video. Since topical application produces drug concentrations in joint tissue comparable to oral dosing while producing serum concentrations approximately 10 times lower than oral administration, dramatically reducing the systemic cardiovascular, renal, and gastrointestinal risk profile. Before we continue to the second tier of treatment evidence, here is your pause. Of the 3 strongest evidence-based treatments we have just covered, structured exercise, weight management where relevant, and topical anti-inflammatory medication, which of these have you actually implemented consistently? As opposed to having simply heard about or tried briefly, drop a comment below right now and tell us honestly. This distinction between hearing about a treatment and actually implementing it consistently is precisely the gap this video is designed to help close. Moving to the second tier of evidence, still genuinely well supported but with somewhat more variable individual response than the foundational treatments we just detailed, we find anti-inflammatory nutritional intervention encompassing the comprehensive dietary pattern, targeted supplementation including vitamin D, omega-3 fatty acids, and curcumin, and the specific food categories we have detailed extensively throughout previous videos in this series as either worsening or improving the inflammatory burden that knee osteoarthritis joints are managing. While individual nutritional components generally show more modest effect sizes than exercise or weight management in isolation, the cumulative effect of comprehensive nutritional intervention, combining multiple complementary anti-inflammatory mechanisms simultaneously, the way we detailed in our 5 anti-inflammatory treatments video, produces meaningful additive benefit that genuinely belongs in any comprehensive treatment program. Even though no single nutritional component alone matches the effect size of the foundational exercise and weight management interventions. Physical therapy and manual therapy, including the specific joint mobilization and patellar taping techniques we detailed in our previous non-surgical treatments video, represent another component of this second evidence tier, with research generally supporting meaningful benefit particularly when combined with the structured exercise program rather than as a standalone intervention, reflecting that manual therapy appears to work best as a complement to active exercise therapy rather than as an independent treatment pathway. Bracing and orthotic intervention, including the unloader braces and footwear modifications we have detailed in previous videos, occupies the same second evidence tier, with research supporting meaningful benefit specifically for patients with particular biomechanical patterns, especially those with medial compartment osteoarthritis and varus or bow-legged alignment, where unloader bracing specifically targets the mechanical loading pattern driving their particular disease pattern, representing a treatment whose benefit is genuinely patient characteristic dependent rather than uniformly applicable across all knee osteoarthritis presentations. Now let us address the third tier, treatments with more modest or more variable evidence support, where understanding the genuine uncertainty and the specific patient characteristics that predict better or worse response, exactly as we detailed in our dedicated gel injections video, is essential for making informed decisions about whether these treatments are likely to provide meaningful value for your specific situation. Hyaluronic acid injection, viscosupplementation, which we covered in complete detail in a dedicated previous video, belongs in this third tier, with modest average benefit across the general population but with specific patient characteristics, earlier disease stage, lower body mass index, absence of significant male alignment that predict meaningfully better response, making this a treatment whose value depends substantially on matching the specific patient to the specific characteristics the evidence suggests predict favorable response, rather than this representing a uniformly beneficial or uniformly ineffective treatment across the entire knee osteoarthritis population. Platelet-rich plasma injection occupies a similar evidentiary position, with promising but still maturing evidence, substantial variability in injection technique, and platelet concentration across different studies and clinical practices, and a generally more limited and less consistent evidence base than the foundational treatments detailed earlier in this video, representing a reasonable option to discuss with a physician specifically for patients who have not achieved adequate benefit from the stronger evidence tier treatments, rather than a first-line recommendation given where current evidence places this intervention relative to better established alternatives. Acupuncture, and related complementary approaches, including the specific evidence we detailed in our non-surgical treatments video regarding pain modulation mechanisms, show modest but genuine benefit in several rigorous trials, though with ongoing debate in the research literature regarding the relative contribution of specific acupuncture technique versus the substantial placebo and ritual-based therapeutic context effects that we discussed extensively in the context of the gel injection evidence base, representing another treatment where reasonable clinicians and researchers continue to debate the precise magnitude of specific mechanism-based benefit versus broader contextual healing response. Corticosteroid injection, which we detailed extensively in a dedicated previous video, deserves specific mention within this organized framework as an appropriately targeted tool for acute flare management rather than a foundational ongoing treatment strategy, given its well-documented fast onset but limited duration of benefit and the specific concerns regarding cartilage effects with frequent, repeated use that we detailed in that dedicated video, making this a treatment whose appropriate role within the comprehensive program is genuinely different in character from the foundational, ongoing treatments detailed earlier in this video. Now let us address how these different evidence tiers actually integrate into a single, coherent treatment program, because this integration, rather than any single component in isolation, is what genuinely determines whether a patient achieves the best possible outcome available through non-surgical management. The foundational program, which every patient with knee osteoarthritis should be implementing as the non-negotiable core of their treatment approach, combines the structured exercise program, weight management, where clinically relevant, the comprehensive anti-inflammatory nutritional pattern, and topical anti-inflammatory medication as needed for symptom control. This foundational program alone properly and consistently implemented over the 8 to 12-week timeline that we have emphasized throughout this channel as necessary for meaningful structural and functional adaptation, produces substantial improvement for the large majority of patients with knee osteoarthritis, and represents the program that should genuinely be fully implemented and given adequate time before considering whether additional interventions from the second and third evidence tiers are necessary. For patients who have implemented this foundational program comprehensively and consistently but who continue to experience symptoms significant enough to affect daily function and quality of life, the second-tier additions, physical therapy and manual therapy, appropriate bracing for the specific biomechanical patterns where evidence supports benefit, and the comprehensive supplementation protocol detailed throughout this series, represent the logical next step, adding complementary interventions to the foundational program, rather than replacing any component of it. For patients who have implemented both the foundational program and appropriate second-tier additions, but who continue to experience inadequately controlled symptoms, the third-tier interventions, hyaluronic acid injection for patients matching the favorable response characteristics we detailed, platelet-rich plasma for appropriate candidates, or corticosteroid injection for acute flare management specifically, represent additional tools to discuss with your physician, understanding the more modest or more variable evidence support these specific interventions carry compared to the foundational and second-tier treatments. The question of how long to trial each tier of this comprehensive program before determining whether progression to the next tier or, ultimately, to surgical consultation is appropriate deserves more specific guidance than the general framework we have provided so far, because vague timeline guidance is precisely the kind of incomplete information that leaves patients uncertain about whether they have genuinely given a treatment adequate opportunity to work before moving on. For the foundational tier, structured exercise, weight management, anti-inflammatory nutrition, and topical medication, the research on tissue and functional adaptation timelines we have detailed throughout this channel consistently supports a minimum trial period of 12 weeks of consistent, properly implemented practice before evaluating whether this foundational program has produced its full potential benefit. This 12-week minimum reflects the genuine biological timeline required for the muscle strengthening, the structural and inflammatory tissue adaptation, and the cumulative anti-inflammatory dietary and nutritional effects we have detailed extensively throughout previous videos, and represents a timeline that, when compressed or abandoned prematurely, frequently leads to inaccurate conclusions that the foundational program did not work, when in reality, it was never given adequate time to produce its genuine effect. For the second-tier additions, physical therapy and manual therapy, appropriate bracing, and comprehensive supplementation, a similar 8 to 12-week evaluation period, implemented concurrently with continued foundational program adherence rather than as a sequential replacement, allows adequate time to assess whether these complementary interventions are providing meaningful additional benefit beyond what the foundational program alone achieves. For the third-tier interventions, particularly the injection-based treatments, hyaluronic acid and platelet-rich plasma specifically, the evaluation timeline is somewhat different and more treatment-specific, since these interventions, unlike the ongoing lifestyle and rehabilitation interventions of the first two tiers, represent discrete procedures with their own specific expected onset and duration of action that we detailed in their respective dedicated videos, typically requiring 4 to 6 weeks following the injection itself to assess whether meaningful benefit has been achieved rather than the broader 12-week timeline appropriate for the ongoing lifestyle interventions. The decision regarding surgical consultation deserves its own specific guidance beyond simply stating that it should occur after comprehensive non-surgical treatment has been exhausted, because the practical question of when exactly to seek this consultation and what that consultation should specifically address matters considerably for how patients actually navigate this transition point in their treatment journey. Surgical consultation, even when surgery itself may not yet be indicated or may ultimately not be necessary, can appropriately occur in parallel with the comprehensive non-surgical program we have detailed, rather than exclusively as a sequential step that only happens after non-surgical treatment has definitively failed. An orthopedic surgeon consultation early in the treatment process, specifically framed as gathering information about disease severity, surgical candidacy, and realistic expectations about surgical outcomes for someone with your specific disease characteristics, provides valuable planning information and establishes a relationship with a surgical specialist before any urgent decision-making is required, while the actual decision to proceed with surgery remains appropriately deferred until the comprehensive non-surgical program detailed throughout this video has been given adequate opportunity to demonstrate its potential benefit. This parallel track approach, rather than a strictly sequential one, reflects the genuine complexity of real-world treatment decision-making, where gathering information and establishing appropriate specialist relationships need not wait until every non-surgical option has been definitively exhausted, even though the actual treatment decision itself should appropriately await that comprehensive trial. The role of shared decision-making throughout this entire process deserves final emphasis, because the framework this video has provided is designed to inform a collaborative conversation with your physician and physical therapist, not to replace the conversation with a rigid, one-size-fits-all algorithm that ignores your individual circumstances, preferences, and the specific characteristics of your particular disease presentation. The evidence tiers we have detailed represent population-level evidence strength, genuinely useful for understanding where to prioritize your initial treatment efforts, but your individual response to any specific component, your personal capacity and circumstances for implementing different elements of this program, and your own values and priorities regarding the trade-offs between different treatment approaches all appropriately inform how this general framework gets adapted to your specific situation in partnership with the healthcare providers managing your care. The cost dimension of this comprehensive multi-tier treatment program deserves direct, practical discussion, because the genuine financial reality of implementing this complete framework varies considerably depending on insurance coverage, access to physical therapy and other rehabilitation services, and the specific second and third tier components a given patient's situation may warrant. And this practical reality appropriately factors into how patients and physicians navigate the sequencing and prioritization of this framework in actual practice. The foundational tier, fortunately, carries the most favorable cost profile of any component in this entire framework. Structured exercise can be learned and implemented with minimal or no ongoing cost beyond an initial period of instruction, whether through a physical therapist, a properly designed home program, following the detailed guidance we have provided in previous videos, or a combination of both. Weight management, similarly, carries no inherent treatment cost beyond the food choices that comprehensive nutritional intervention already involves. Topical anti-inflammatory medication is available over the counter in many regions at relatively modest cost compared to many other pharmaceutical interventions. This favorable cost profile for precisely the treatments with the strongest evidence base represents one of the most encouraging aspects of this entire framework. The treatments most strongly supported by evidence are also, generally, the most financially accessible, removing cost as a barrier to implementing the component of this program that matters most. The second and third tier components carry more variable cost profiles, with physical therapy often requiring insurance coverage or significant out-of-pocket expense depending on coverage specifics. Bracing and orthotic devices ranging from relatively affordable over-the-counter options to more expensive custom-fitted devices. And the injection-based third-tier treatments frequently representing the most significant out-of-pocket expense in this entire framework, as we detailed specifically in our dedicated gel injection video regarding hyaluronic acid costs. This cost gradient, where the strongest evidence treatments are generally most affordable and the more variable evidence treatments are generally more expensive, provides additional practical reinforcement for the tiered prioritization this video has detailed. Not only does the evidence support beginning with the foundational tier, but the financial accessibility of this tier removes practical barriers that might otherwise complicate implementation. While the more expensive third-tier options, with their more modest and more variable evidence support, appropriately remain reserved for patients who have already received substantial benefit from the more affordable, better evidenced foundational and second-tier interventions, and are specifically seeking additional improvement beyond what those interventions alone have provided. Only after this complete, comprehensive, properly sequenced non-surgical treatment program has been genuinely implemented, given adequate time to produce its full potential benefit, and found to provide an adequate symptom control and functional capacity for an individual patient's specific needs and goals, does surgical intervention become the appropriately indicated next step, representing the conclusion of a comprehensive treatment process rather than a default option pursued without first exhausting the substantial evidence-based non-surgical treatment landscape. This video has detailed in complete organized form. This is the complete, evidence-organized picture of non-surgical treatment for knee osteoarthritis, the foundational, strongest evidence treatments that belong at the center of every treatment plan. The second-tier additions that provide meaningful complementary benefit, the third-tier options that require patient-specific consideration given more variable evidence, and the integrated, properly sequenced program that combines all of these into the comprehensive approach that the strongest available evidence genuinely supports, rather than the fragmented, partial implementation that so many patients receive when no single source provides this complete, organized picture. If this video gave you the complete, evidence-organized framework for non-surgical knee osteoarthritis treatment that brings together everything this channel has covered into a single, coherent program, please support this channel. Hit the like button right now. Subscribe if you have not already, because we are committed to providing exactly this kind of complete, properly organized treatment guidance. Share this video with someone who has been told they might need knee surgery and deserves to know whether they have genuinely exhausted the complete non-surgical treatment landscape first. And leave a comment below. Tell us which tier of treatment you are currently implementing and what your next step should be based on the framework this video has provided. We read every comment. Thank you so much for watching. See you in the next one.